Imagine a plumber tells you that he's going to fix a leaky pipe in your house.
Okay.
But instead of, using a wrench and tightly bolting this rigid bracket around it, he's just going to string up a tiny loose hammock underneath the pipe.
Just a hammock.
Yeah, completely unattached. And then he's just going to wait for the house's foundation to slowly crush in around it to hold it in place.
Right, which sounds, that sounds like an absolute engineering joke.
Totally. But if you are one of the millions of women undergoing surgery for stress urinary incontinence, this is exactly the mechanical reality of your pelvic floor.
It really is. It's a fascinating procedure.
It is. So welcome to today's deep dive. Today we are taking the mid-urethral sling and, the decades of rigid, paralyzing rules that go with it and putting it under the microscope.
Because there are a lot of rules.
So many. And we are zeroing in on one highly practical question for you today. After this surgery, what are the actual scientifically backed long-term restrictions on heavy lifting? Like if you want to get back to the gym or your physically demanding job or, just safely pick up your kids, what does the physics actually dictate?
And finding the answer to that
Right.
requires untangling a lot of historical assumptions.
Yeah.
Because when we actually look at the data, like the biomechanical models, the randomized clinical trials, the structural engineering of the human pelvis, we see a medical establishment that, well, for a very long time, relied on fear and tradition rather than basic physics.
Which is wild to think about.
It really is. The journey to understand what you can and cannot lift reveals a massive real-time paradigm shift in how we view surgical recovery.
Okay, let's unpack this. Because before we can talk about throwing weights around, I really want to understand the hardware.
Sure, let's start with the basics.
We are talking about stress urinary incontinence, or SUI. And the sources basically describe this as mechanical failure.
Exactly.
The urethra sags out of its proper anatomical position, or the sphincter muscle controlling the urine flow is just too weak.
Right, so the closure mechanism is compromised.
So the moment your body experiences a spike in intra-abdominal pressure, like you cough, you sneeze, you laugh, maybe jump off a step, the plumbing just gets overwhelmed and you get leakage.
Yeah, it is entirely a pressure management problem.
Okay.
Think of it like this. The pelvic floor is supposed to act like a dynamic trampoline, absorbing that downward force.
Knocks him back.
Exactly. But when those muscles or ligaments are compromised, often from childbirth, genetics, or age, the urethra essentially loses its backstop.
It has nothing to press against.
Right. When the pressure hits, there's nothing solid for the urethra to be compressed against to stay closed.
So it just leaks.
Yeah. So in the mid-1990s, the medical community introduced the mid-urethral sling.
And this is the gold standard now.
It is. It's a minimally invasive outpatient procedure. It takes about 20 to 30 minutes.
That fast.
Super fast.
Yeah.
And the success rates are phenomenal. Typically, 80 to 90% of women see a long-term cure or, a massive improvement.
That's huge. But I want to focus on the physical object itself because the material really matters for what we're talking about today.
Definitely.
They are implanting a narrow strip of synthetic mesh. Usually it's a permanent plastic called polypropylene, right?
Correct.
And the surgeons essentially have two main routes to put this in. There is the retrocubic approach, the TVT, where they guide the mesh up behind the pubic bone.
Right, the TVT.
Then there is the transobturator approach, the TOT, where they pass the mesh horizontally through the groin area.
And those two approaches actually create very different mechanical environments.
How so?
Well, the TVT, going up behind the pubic bone, creates a distinct U-shape around the urethra.
Like a tight horseshoe.
Exactly. So when abdominal pressure spikes, that steep U-shape acts almost like kinking a garden hose to stop the flow.
Oh, I see.
Whereas the TOT, going horizontally through the groin, creates a much flatter, shallower hammock.
Like the hammock we talked about earlier.
Right. It acts more like a supportive beam that the urethra just rests on when pressure pushes it downward.
Okay, that structural difference makes sense. But here's the part of the procedure that honestly stopped me in my tracks when I was reading the clinical notes.
What's that?
Once the surgeon gets this mesh hammock into the perfect position under the urethra, how do they bolt it down? Like, do they stitch it directly to the pubic bone or anchor it into the pelvic sidewalls?
They don't.
Wait, what?
There are absolutely 0 stitches holding the actual sling in place.
None at all.
None. It is placed entirely tension-free beneath the mid-urethra, literally just resting there.
Wait, I need you to explain the physics of that. Are you
Yeah.
telling me a surgeon just leaves a loose piece of plastic floating inside the pelvis?
That's exactly what I'm saying.
But if a patient stands up off the operating table, what stops gravity from just pulling the mesh straight down into her leg?
It comes down to the microscopic texture of the mesh itself.
The plastic.
Yeah, the polypropylene isn't like smooth plastic. It's woven, almost like a piece of Velcro. The moment it touches the surrounding pelvic tissue, the friction of that weave grips the tissue.
So it's scratchy.
Exactly. Think of a Chinese finger trap. The tissue catches in the pores of the mesh instantly,
Wow.
but, that's just the initial temporary hold. The long-term stability relies on a deliberate biological reaction called fibroblastic ingrowth.
So the body is actively attacking it.
In a highly controlled way, yes. Polypropylene is chosen specifically because it incites a very specific, mild, inflammatory response.
Like it knows it's a foreign object.
Right. The body recognizes it as a foreign object
Yeah.
and sends macrophages and fibroblasts to the area.
And what do they do?
Over the course of about 4 to 6 weeks, those cells lay down dense collagen, basically scar tissue, directly through the pores of the mesh.
Oh, wow.
It's not like a house settling and crushing the hammock. It is much more like planting a plastic trellis in a garden.
A trellis. That's a great visual.
Yeah, the ivy, which is your body's native scar tissue, aggressively grows through every single hole in the trellis. It intertwines with it until the plastic and the human tissue are one solid, unified structure.
Okay, framing it as a trellis makes so much more sense to me. The surgery doesn't secure the implant. The body scarring into the implant secures it.
You've got it.
And because it takes 4 to 6 weeks for that IV to fully intertwine with the plastic, I can completely see how the medical world became obsessed with keeping patients completely immobilized.
Yes.
Which brings us to the traditional rule book, the dreaded lifting restrictions.
Right. The assumption was pretty simple. If you strain your abdominal muscles before the scar tissue has fully integrated, you'll blow the mesh out of place.
Or cause it to migrate.
Exactly. And then the surgery will fail.
And doctors were incredibly rigid about this. I mean, the guidelines show women were routinely told, no heavy lifting, strictly capping them at like 15 to 25 pounds.
Sometimes even less.
Yeah, no high-impact sports. Complete pelvic rest for 4 to 6 weeks. And in some older guidelines, these restrictions dragged on for up to 12 weeks.
A quarter of a year.
They were treating women like fragile porcelain dolls, but when researchers finally stepped back and looked at the actual biomechanics of the human body, the physics of this advice completely fell apart.
It is a glaring physical contradiction.
Seriously.
The restrictions completely ignored the reality of what the pelvic floor experiences during just passive everyday life.
Right. Here's where it gets really interesting. One of the biomechanical studies measured intra-abdominal pressure, so the downward force hitting the pelvic floor.
Yeah.
They found that simply changing your position from sitting in a chair to standing up creates a 13-pound increase in abdominal pressure.
Just standing up.
Just standing. And sneezing or coughing creates a massive, violent spike in pressure.
Huge spikes.
Even straining to pass a stool when constipated blasts the pelvic floor with sustained force.
A lot of force.
So, if a sneeze or just standing up subjects the healing mesh to that much brute force, banning a woman from picking up a 20-pound dumbbell feels completely arbitrary. Are we just punishing patients for no scientific reason?
What's fascinating here is this is a classic example of expert opinion operating in a complete vacuum of actual data.
Just guessing, basically.
Essentially, yes. For decades, the 15-pound lifting limit was passed down from attending physician to medical resident purely through tradition.
Wow.
They assumed lifting 20 pounds was dangerous, but nobody had actually tested the detachment strength of the mesh during those vulnerable first few weeks.
But they finally did test it, and the results in the animal models are wild.
They really are.
Our sources highlight an in vivo rabbit model. Scientists implanted this exact polypropylene mesh into the abdominal walls of rabbits.
Right.
Then, at various intervals, they attached a mechanical tensiometer and literally tried to rip the mesh out to measure the pull-out force required to make it fail.
Just mechanically yanking on it.
Yeah. And what did they find?
What they found completely dismantled the 6-week waiting period.
Really?
By just 7 days post-implantation, the force required to detach the mesh was remarkably high.
Just 1 week?
Just 1 week. The tissue integrates into those pores, creating that trellis effect we talked about, much faster and with significantly more tensile strength than doctors had ever assumed.
So it's basically locked in.
The mesh grips fast and it grips hard.
Well, if the rabbit model proves the mesh holds tightly within a week, and we know that a simple sneeze violently pressurizes the abdomen anyway, it begs the question,
Which is,
did anyone actually dare to test this on humans? Like, did anyone look at a woman who just had surgery and say, go ahead, go straight back to the gym?
yes, they actually did.
Really?
The sheer illogic of the restrictions prompted a massive reevaluation in urogynecology, which led to some rigorous randomized controlled trials.
Okay, what did they do?
First, researchers simply cut the restriction time in half.
Just to test the waters.
Right. They took women who just had the sling surgery and gave one group the standard 6-week restriction and another group a 3-week restriction.
And what happened?
The result was exactly what the physics predicted. Returning to normal activities at 3 weeks led to significantly higher patient satisfaction, with absolutely zero compromise to the surgical success.
Zero compromise.
None. But that wasn't far enough for some researchers.
No.
No. The multi-center trial led by Lai and colleagues is where the envelope really gets pushed.
Oh, I read about this one. It's crazy.
They designed a non-inferiority trial,
Meaning?
meaning they weren't trying to prove that doing deadlifts right after surgery magically cured incontinence better. They just wanted to prove that it wasn't worse than resting.
Okay, that makes sense.
So they pitted a standard restrictions group against a liberal activity group.
And the instructions given to the liberal activity group are almost shocking to read, honestly.
Very unconventional.
They were told they could resume any activity they wanted immediately, at their own discretion. Zero weight limits on lifting.
No weight limits. The day after surgery.
Like, if you feel fine, go lift a couch.
Basically, yes.
That blows my mind, because I think of being forced to drive 10 miles per hour on an empty highway for weeks just because a mechanic fixed your brakes, you know?
That's a great analogy.
And the clinical outcomes of that liberal activity protocol were what?
Totally not inferior.
Unbelievable.
When they looked at the surgical failure rates, the rates of the mesh exposing or extruding or any other complications, they were statistically identical between the two groups.
So resting didn't make it any safer.
Not at all. Pushing the body early did not cause the mesh to fail. In fact, the group that was allowed to move freely actually reported fewer pelvic floor symptoms overall.
Imagine the psychological relief of that. I mean, being told not to move when you feel fine is maddening.
And it has real-world consequences.
Exactly. I think about the economic and professional impact this has had.
Huge impact.
Telling a nurse who has to transfer patients, or a warehouse worker, or just a mother with a toddler that she cannot lift more than 15 pounds for 6 weeks.
You're sidelining them completely.
Yeah, you are effectively forcing her out of her livelihood and her life. And for what? For a fear that never materialized in the data.
Exactly.
So for the listener who brought us this mission today, who wants to know about the rest of their life, I feel like we can give a very definitive answer.
We absolutely can.
So what does this all mean?
The long-term answer is that there are zero restrictions on heavy lifting after you recover from a mid-urethral sling placement.
Zero.
Zero. Once you are past that initial healing window, which new data suggests is incredibly short if it exists at all for comfortable movement, patients are fully encouraged to return to high-impact sports, manual labor, and heavy lifting.
So if you are a weightlifter or a physical worker, you don't have to choose between a leak-free life and an active life. You get to have both.
You do.
But, I want to dig into a fascinating twist in the sources, because it turns out long-term exercise isn't just allowed after this surgery.
No, it's not.
It is actively protective.
Yes.
A 2023 study by Ferrante followed 351 women after their sling surgeries. And logically, you might think the women doing heavy squats or deadlifts over the years would, slowly wear out their slings and start leaking again.
That would be the traditional assumption, yeah.
But the data showed the exact opposite.
The statistics are so compelling. Women who engaged in higher levels of strenuous exercise, which they defined in the study as 90 minutes or more of strenuous activity per week, reported significantly lower rates of their incontinence returning 2 years after surgery.
Lower rates.
Yes. The heavy exercisers had a 12.8% recurrence rate,
Okay.
compared to a 26.6% recurrence rate for those who exercised less.
Wait, really? Lifting heavy weights literally cut the surgical failure rate in half.
And a half.
How does that work mechanically? If the mesh is just a static piece of plastic under the urethra, why would doing a heavy deadlift make the plastic work better?
If we connect this to the bigger picture, it makes a lot of sense. The mesh isn't operating in a vacuum.
Right.
It is surrounded by the dynamic muscular system of the pelvic floor, specifically the levator ani muscles.
Okay.
The human body thrives on load-bearing activity. When you lift heavy weights, Your core and pelvic floor reflexively contract to stabilize your spine and pelvis.
They brace.
Exactly. So over years of strenuous exercise, you are constantly maintaining the baseline tone, thickness, and reflex strength of those surrounding muscles.
So the sling is basically just the emergency backstop.
Precisely. The active, strong muscles do the heavy lifting, pun intended, of keeping the pelvic organs elevated and supported.
And when the muscles do the work.
The sling is under less chronic strain.
That makes total sense.
And this dynamic is exactly why organizations like NICE in the UK strongly highlight pelvic floor muscle training, or PFMT, as a highly effective first-line treatment.
Before even trying surgery.
Right. For about half of women, actively strengthening the muscles provides enough urethral support to avoid surgery entirely.
Wow. Okay, up to this point, this procedure sounds like a flawless miracle.
It does sound pretty good.
Right, a 20-minute outpatient surgery, your leaks stop, it grips the tissue in a week, you can go back to powerlifting, and the lifting actually protects you.
Yeah.
But we are talking about permanently injecting synthetic plastic into the human body, and the sources make it very clear that this is not a consequence-free intervention. We have to look at the complications.
Absolutely. As a medical professional, this is where we have to balance the enthusiasm of the success rates with the reality of surgical risk.
Yeah.
Because while the mid-urethral sling is the gold standard, the complication rates are real. Post-surgery, 5 to 15% of patients experience temporary urinary retention.
Which means they physically cannot empty their bladder.
Right.
Why does that happen?
It usually comes down to the tension of the mesh or the swelling of the tissue. If the surgeon places the sling even slightly too tight, or if the U-shape of a TVT sling kinks the urethra too aggressively, it obstructs the flow of urine.
Does it stay like that?
It often resolves as swelling goes down, but sometimes it requires the surgeon to go back in and loosen or cut the mesh.
Oh, wow. Okay, what else?
Beyond retention, 10 to 15% of patients will deal with urinary tract infections.
That's fairly high.
And more seriously, there is a 1 to 4% risk of mesh erosion or extrusion, where the rough plastic actually wears through the vaginal wall or into the bladder.
That sounds incredibly painful.
It is. And critically, about 1 in 10 women may experience chronic pelvic pain or pain during sexual intercourse.
And we cannot talk about those complications without addressing the massive public fear around the word mesh.
Right.
There have been major lawsuits and documentaries about transvaginal mesh ruining lives, but the sources clarify this distinction very carefully.
Yes, the distinction is crucial.
The FDA has severely restricted and banned transvaginal mesh when it is used for a different condition called pelvic organ prolapse, or POP, which involves using much larger sheets of mesh to hold up dropping organ.
Right, much more material.
But the FDA has not recalled the narrow mid-urethral slings used for stress urinary incontinence. They still categorize them as safe and effective.
They do.
That said, the UK government took a much harder stance, entirely pausing the use of synthetic slings in 2020 for a sweeping safety review.
Which is a big deal.
Yeah, noting that while the majority of women had great success, the minority who suffered complications were left without adequate support or solutions.
It highlights the agonizing risk-benefit analysis every patient has to navigate.
It really does.
And this leads us to one of the most compelling pieces of research in our stack. A preprint paper by Shen and colleagues.
With a physics paper.
Yes. They approach this not from a clinical outcome perspective, but purely from a materials engineering and physics perspective.
Right.
And they raise a profound critique of the entire tension-free hammock theory.
This paper is fascinating because it focuses on a concept called Young's modulus, which is essentially a measure of stiffness.
Yes, exactly.
The researchers argue that biological tissue, like the vagina, the urethra, the pelvic floor, is highly elastic. It is viscoelastic. It stretches, it contracts, it expands.
It's meant to most.
Right. But polypropylene mesh is inelastic.
Yeah.
It is rigid.
Right.
So when you fuse a highly elastic biological system with an inelastic piece of plastic, you create deterministic mechanical friction.
This raises an important question. It's an unavoidable clash of material properties.
I picture it like threading a rigid steel cable through the center of a stretchy bungee cord.
That's a perfect visual.
On day one, they're perfectly aligned, but over the course of 10 years, every time you cough, jump, or sneeze, the bungee cord stretches 20%, but the steel cable only stretches 1%.
Right.
At the microscopic points where they are attached, that sheer difference in elasticity is going to cause the steel to essentially saw into the rubber. Over millions of microscopic movements, you get wear and tear. But I have to ask, if that physics logic is so airtight, how do we reconcile it with the clinical reality that 80 to 90% of women have incredible pain-free success with this surgery?
Well, you reconcile it by recognizing that biological systems are remarkably resilient, but they're still subject to the laws of physics.
Okay.
The clinical data is undeniable. For the vast majority of women, the body's scar tissue integrates with the mesh so well that it successfully distributes those shear forces.
So it spreads the load.
Exactly, giving millions of women their active lives back. That is a massive medical triumph.
Truly.
But Shen's physics critique is the missing puzzle piece that likely explains the failures.
The 1 to 4%.
Right. That mismatch in elasticity, that microscopic sawing effect over thousands of stretches, is a highly plausible explanation for why that 1 to 4% erosion rate exists, or why 1 in 10 women develop chronic pain.
It's just constant friction.
Yes. It is a vital reminder to the medical community that just because a procedure is the gold standard doesn't mean the engineering is perfect. We cannot declare the problem solved and stop innovating.
I couldn't agree more. So, synthesizing everything we've uncovered today, the narrative arc is incredibly clear.
It really is.
We set out to find the long-term heavy lifting restrictions after a mid-urethral sling, and the answer is zero.
Zero restrictions.
The historic mandates to avoid lifting a 15-pound box for 6 weeks are currently being completely dismantled by aggressive, liberal activity clinical trials.
Physics wins out.
Yeah, we've learned that gravity and a simple sneeze put way more stress on a new implant than a dumbbell does.
Exactly.
And most surprisingly, engaging in long-term, strenuous, heavy exercise doesn't break the sling. It actually halves the likelihood of your incontinence returning by fortifying the muscular backstop.
It's empowering data.
It is. If you are a patient staring down the surgery, the medical paradigm is shifting away from treat your pelvis like fragile glass to get back to living a heavily active life as soon as your body tells you it's ready.
It is a genuinely empowering shift in patient care. We're moving from fear-based restriction to evidence-based freedom.
Absolutely.
But I want to leave you with one final provocative thought that builds on the physics mismatch we just discussed.
Oh, I like a final thought.
We know the polypropylene mesh is a permanent, non-absorbable plastic. It will outlive you.
Right.
But the human body is constantly in flux. Over the span of 30 or 40 years, our pelvic tissues naturally atrophy. We lose collagen,
We get older.
we go through menopause, and our entire estrogen and hormonal landscape fundamentally alters the elasticity and shape of our organs.
Oh, wow. I didn't even think of that.
So the provocative question that researchers have to grapple with next is this. What happens to a permanent, unyielding piece of rigid plastic when the dynamic biological landscape it was perfectly calibrated for fundamentally changes its shape and composition 3 decades later?
Man, that is exactly the kind of friction that forces modern medicine to keep evolving. Fixing the dynamic human body is infinitely more complex than a plumber stringing a hammock under a leaky pipe. Thank you for joining us on this deep dive. Keep questioning the standard advice, read the clinical data, and stay curious. We'll catch you next time.